This slide presentation presents a breast replacement option for surgical reconstruction for those who have had a mastectomy of one or both breasts as a result of having cancer. This procedure is a fairly new procedure and is being performed locally on a regular basis by those who choose to have this option. Of course, the options are still available as in the past of prosthesis and other methods and so forth. This is just a new technology that has changed the face of the way we look at the procedure of having a mastectomy and returning the patient more to a full and vital lifestyle in a permanent basis. In this particular slide, we noticed some of the things that have been localized to this area. We have Buddy Check 12, which is part of Channel 12's initiative to make people aware of checking for breast cancer. We also see that our government's behind breast cancer by National Breast Cancer Awareness Month. We have 6.2 Run with Donna. She happens to be one of the news anchors for Channel 12, and this is a program that's put on here every year. And in the upper top, we see her and her husband running in the show itself. We also have a Facebook page that has been dedicated to this particular subject with all of those of Channel 12 that have a firm commitment to see the process through. We've been using the term DIEP flap in this conversation regarding this procedure. DIEP flap, or the DIEP word DIEP, D-I-E-P, is nothing more than an acronym which stands for Deep Inferior Epigastric Perforators. So what is the DIEP flap reconstruction? Well, basically, it is an elective surgery, like we mentioned earlier, so that's not an emergency type situation, and it is to repair the locations where one or more breasts have been removed. And it, as we said previously in the opening slide, it is a solution that provides a closure for the patient. Therefore, as a result, they don't have to go through using the old methods of using prosthesis or other temporary type of equipment that has a possibility to move or dislodged or something, and providing them in some kind of embarrassment as they go out in public. The DIEP flap surgery for breast reconstruction simply is nothing more than using extra skin and fat from the tummy after a tummy tuck and reattaching that particular fat and skin along with its arteries and veins from the stomach area to the breast area. Before the DIEP process is attempted, the patient will have undergone a single or double mastectomy, and then that involves the lymph node and lymph vessel removals as well as part of the surgery. Typically, this is done by a surgical oncologist because of the cancer being involved. Then at the end of the mastectomy procedure, a portacatheter will be placed for future use. There may be a series of treatments with chemotherapy or radiation or both. The DIEP process can be completed during the mastectomy if no chemotherapy or radiation is being done. So they can just do it all at once if they want. They just need to keep up with the pace of it and make sure that they don't keep the patient under anesthesia extremely long. So, you know, the one issue, though, involved with this process is the candidate must have enough abdominal tissue for the procedure to be done. The deep flap procedure involves two surgical teams, one that will be working in the abdominal area or abdominal section, while the second team prepares the chest wall site. The procedure consists of basically plastic surgeons as well as those that have some abdominal experience and background. They will begin prepping both sites to identify the epigastric vein and artery as well as the mammary vein and artery. The deep flap is created from the abdominal tissues with the vein and arteries intact. Then, uh, then they're transported to the chest wall site for reconnection. The uh, the epigastric veins are connected via anastomosis, which is a fancy term for this a microscopic surgical connection of very small veins and arteries into the internal mammary vein. The artery is the same, except it's obviously connected to the internal mammary artery. Once all veins and arteries are connected, the surgeon checks for blood flow and circulation. A separate flap will be created for each site. The procedure continues with the abdominal team beginning to close up the abdomen and the chest wall team beginning to breast fit and shaping of the new flaps or breast tissue. Jackson Pratt veins are installed and placed one at each breast and one at the abdominal section for proper drainage. The flaps are then secured in place and positioned by sutures, steri-strips, and mastisol, which is simply a liquid adhesive. Patients are then fitted with a sports bra and abdominal binders and then returned to the rooms once their anesthesia has wore off. Here we see the deep flap process in a pictorial form. In the center slide, you'll see a fat and skin removal from the tummy area, the stomach area, with the artery and vein intact, and then relocated into the breast area for reconnection and usage. The surgery itself, it is, like as we said, it's a microscopic surgery. It requires some special tools and equipment, as well as specialized training for the surgeons. Very delicate work. Sutures used to reconnect the blood vessels, as we said the word was anastomosis, is about the diameter of a strand of your hair. Patient is discharged from the hospital in approximately 3 or 4 days, depending upon their recovery. Let's look at some of the advantages and disadvantages of the deep breast cancer reconstruction. With the deep flap reconstruction, advantages include things like minimal impact on the abdominal walls, as well as quicker recovery. In the disadvantage area, we have question over proper venous return, and hence the fat may become necrotic depending upon the venous return. And also, the process does take longer. So the next question that may arise from those that are considering this elective surgery after they've had a mastectomy would be, how long after a mastectomy do I have to wait for reconstruction? A simple mastectomy with no complications or breast reconstruction has a recovery time of 1 to 4 weeks. Chemotherapy / radiation is dependent upon what stage of cancer was detected. Chemotherapy is usually given every 2 to 3 weeks for 3 to 6 months. Recovery time varies, and patients are advised to plan for 1 to 3 months of recovery time. So in that case, a mastectomy is done, then the chemotherapy and or radiation so basically you need to add the times for whatever is happening after the mastectomy. If it be chemo, if it be radiation, if it be both, and then can come the process after they're totally um, set up and healed from that to where they can do the elective surgery for the DIEP flap. Also, external radiation treatments last 6 to 7 weeks. Internal radiation procedure may take as little as 5 days, while others may take up to 3 weeks to complete. It just depends upon what the oncologist has selected to do. Can the DIEP procedure be used with a single or a double? Yes, it can be used with one or both. Um, if you've had any kind of abdominal tissue that's been removed before, then you'll need to do a different type of procedure to do this. But the only uh, deal in the process here is that in order to do two of them, that you just need to have enough skin and fat to do both. The protocol following the surgery in the first week, the patient will be restricted with a weight restriction of 5 pounds. They're not to lift any more than that. They don't want the patients to raise the arms above the head, either frontward or to the side. The patient is limited to light walking 2 to 3 times a week. Um, they'll walk with the trunk flexed a little bit at the hips forward. First week, they would avoid ice and heat over the incision. The patient is also asked to limit their caffeine intake as it decreases the blood flow during that first week. They're to avoid direct pressure over the chest. Use of a pillow in the car between your body and the seat belt is a good idea during that first period of time. The patient will wear a sports bra and abdominal binder at all times during this first week. No pushing or pulling with the arms are recommended. This first week they're asked to only do sponge baths, no shower, no tubs, none of that, no soaking. Of course, they're restricted from driving, and then we say that there's no BLT. That means no bending at the hips where you'll be using the abdominal muscles. No lifting the trunk like from a lying position to where you'll be doing like a sit up off of a laying down, doing a sit up. And then the third thing is the T part, which is no twisting of the trunk of the body. And then the patient is also requested to avoid wearing any underwire bras to help the healing process of the new reconstructed breast. The protocol continues the second week with the first post-op visit at the surgeon's office to remove some of the Jackson Pratt drains. The second week they can begin, as long as they've been released by the physician, they can begin showers, but no tub soaking. Now, again, the physician will go all over this with them in the office, but at this point they can begin raising their arms overhead, but still limited to no pushing or pulling or lifting. Then this particular week, the physician normally likes them to begin working on their home exercise daily program. Week 3 will be another visit with the doctor at their office to remove any remaining drains that may be left. And towards the end of the week, the doctor may be releasing them to drive again. In the fourth week, we'll be looking at the third and final visit, unless something else is going on, to the surgeon's office, and the surgeon will decide whether to cut them loose or not for additional cardio activity. During week 5, they should feel almost back to normal. They may have some occasional pain in the breast and the abdominal area, but the patient is advised that this should be normal for the type of procedure they had. During week 6, they'll be released from all restrictions and return to work. So I mean that's quite lengthy time to be out of work 6 weeks, but that's the protocol they're using right now. Of course, they may begin during this 6 weeks some sexual activity. Uh, they can begin to do scar massage by the end of this week as well. Of course, these are general guidelines and protocol and may be adjusted at any time by the surgeons. Then, basically, after 3 months is when the physician would normally recommend abdominal exercises can be begun. So, with the patient, there will be some nursing considerations that we may want to take a look at. Some of the nurses are with the patients majority of the time, especially like in the hospital settings and so forth. And if they require any home health, most of the time the nurses will be coming out. There may be an additional physical therapy or occupational therapy ordered, again, depending upon the patient. But nursing will definitely be involved with the incisions and especially the drainage and these kind of things, the sutures and so forth. What will the nursing be looking at? They'll be looking at some anesthesia risk. So how long are they been under anesthesia? What kind of problems could be caused and so forth. Um, looking at things like their respiration, if they have any decreased respiration, if they have any infection, pneumonia. Um, they'll have them do some coughing, deep breathing, perf lift techniques, and so forth. Um, then they will also be concerned with um, decreased mobility, increased risk of pressure ulcers, deep vein thrombosis, pulmonary embolisms. They'll be educating the patients on the hazards of immobility, constipation, those kind of things. Surgical risk, they may be looking for infections secondary to multiple surgical incisions. They may be looking for dehydration, decreased nutrition. Um, they may have some pain management things to address with the patients. Medication side effects and decreased knowledge um, of use of those medications. They may be doing a lot patient education about the drains, the integumentary system status related to surgical sites, the skin and such, the abdominal binder usage. They will probably even have some patient education regarding swelling, lymphedema, and just general hygiene care. Um, then the nursing will also address with the patient some nutrition items like their appetite, healthy eating, foods easy on the stomach that they may want to look at using for a little while. Um, the idea of doing small meals and avoiding like big large meals and avoiding foods that are spicy, greasy, fatty foods, those kind of things, and adding protein to their diet. Um, Another clinician that will be involved in the process will be the physical therapy. That could either be the physical therapist or the physical therapist assistant. The initial visit will be done by the physical therapist for evaluation, and it could be turned over to an assistant. And some of it will be depending upon how long that they are um, in the hospital location and setting. But basically, the physical therapist will again focus on some of the same things the nurses might have done, like the deep breathing techniques. And the physical therapist will have them take deep breaths in their nose and push it out their lips while their lips are pursed like a kiss. So they'll be slowly pushing it out their lips and taking deep breaths through the nose to increase that airflow in that canal and such. The physical therapy will be highly involved in teaching them a different kind of mobility, specifically a log rolling techniques where they're laying down on the bed like a log and just rolling out of the bed and sitting up. Basically, we're trying to keep them from avoiding them to sitting up using those abdominal muscles, like we spoke about before. No BLTs. They'll be working on some strengthening, helping them with gait training, getting their body back oriented. That remember, this is how you're supposed to walk. This is the proper pattern of walk. Trying to keep them from doing too much correctiveness with that. They'll also do the same thing regarding the stairs. They will be issued a home exercise program to take home with them where they can do it themselves. And any patient education regarding these things. The how long, what should we look for, those kind of things. Equipment training, if they have any equipment that they've been released to take home with, the physical therapy will do that. Work with them on their balance, make sure they're not having any balance issues. Because of the surgery and because of what's gone on, there's been some major changes happening. We certainly don't want to get them in a position where they hurt themselves. So we want to just double check and do an assessment through the process that their balance is okay, their posture, body mechanics are okay, any considerations with the activities of daily living, and any of their pain management situation. Besides physical therapy, occupational therapy will be involved in the whole process with the patient. Occupational therapy's main concern will be dealing with activities of daily living and mostly associated with their functioning ability in their home and or work environment, and how they proceed with that. They may be teaching them how to use other methods to accomplish the same thing. Um, for example, obviously we're under a 5-pound restriction. They may say, okay, we're not going to lift all of it at the same time. We're going to lift parts of it at the same time to accomplish the same effect. So basically it's patient education about upper extremity body movements, upper extremity limits, again reinforcing the thing, nothing over your head at this time to begin with. They'll be addressing bathing and grooming items. They'll be addressing the clothing. They'll be focusing in on some of the things like the nurses talked about by lymphedema education and checking for that, as well as any upper extremity swelling. The cognitive aspect, the mental aspect of the process, they'll be addressing anything that is of a concern there from the patient or that the therapist may recognize. Pain management will be one of their functions as well, and as we said, any equipment that they may be issued. Then here's the references used to put this together. This was a process that I observed at St. Vincent's Hospital and was assigned to the floor there where the women's unit was at on the 3rd floor.